Hi, my name is Abby, and this is my presentation on my case study for Nursing 601 Advanced Pharmacotherapeutics. My case study was about seasonal allergies in adolescents. So, Kyla is a 14-year-old girl with seasonal allergies. She's been on Claritin for the last month, and it's not helped. She states that there is no way I am doing those nose things. Those are gross. It's really bothersome, and she would like some relief. There are a few pharmacotherapy options for treating allergic rhinitis, in this case her seasonal allergies. They include nasal corticosteroids, antihistamines, leukotriene receptor antagonists, intranasal cromolyn, and immunotherapy. In terms of differentiating which you should use when, it's important to determine from the patient whether these are mild intermittent symptoms, symptoms that are more moderate and persistent and starting to affect quality of life, or whether they're severe persistent symptoms, so symptoms that interfere with sleep, maybe contribute to any asthma exacerbations, or affect school or work performance. In Kyla's case, it sounds like she's experiencing symptoms that are pretty persistent and affecting her quality of life. She seems pretty bothered by them. In that case, it is recommended that you start with intranasal corticosteroid therapy. She has specifically stated in the case before that she is not interested in any nasal therapy. In the interest of recommending the drug of choice, it would be worth discussing with her how this is the most effective option and trying to get to the bottom of what is so gross to her about the nasal therapy and consider whether it would be an option for her. If she truly does not want any nasal therapies, oral antihistamines are an option. There are first and second generation antihistamines. The most common first generation antihistamine is Benadryl, which we all know a fair bit about. The way that that Benadryl is formulated, there is medication that crosses the blood-brain barrier, which contributes to some of the central nervous system side effects like sedation, which many people report. The second generation antihistamines, which include Claritin, Allegra, and Zyrtec, have more complex formulations, so they cause less of those central nervous system side effects, so less sedation, less confusion. You can also take these orally or nasally. For reasons that we discussed above, it seems like Kyla is interested in oral therapy. The leukotriene receptor antagonists, so Montelukast or Singulair, can also be used. These are really only recommended for more severe persistent symptoms, and they are not recommended as monotherapy. So they're meant to be added on to an intranasal corticosteroid or antihistamine, and they're really only if symptoms persist. So not super necessary in her case. Same goes for the intranasal cromolyn, and then the immunotherapy. There are subcutaneous or sublingual immunotherapies. Again, this is really only necessary in severe allergy cases. The cost is quite expensive, and in order for it to take effect, you really have to be getting these shots for many months. Some people are on them for their whole lifetime. And of course, if it's a shot, it does need to be done in a doctor's office, so they can be pretty inconvenient as well. So in Kyla's case, it's definitely not the best choice. There are many other options to try before going to immunotherapy. She doesn't seem to be having super severe symptoms, and there are much cheaper ways to treat her allergies as of right now. There are a few non-pharmacological options. These mainly include allergen avoidance and nasal irrigation. In the case of Kyla, she's having seasonal allergies. It's going to be pretty hard, especially in the spring and in the fall, to avoid pollen. Nasal irrigation, while frequency and concentration of salinity is a little unclear, there is good evidence suggesting that nasal irrigation, in addition to any medication, can really help with symptom relief. As discussed above, Kyla is really not interested in any nasal therapy, it sounds like. So while I would discuss it with her, I'm guessing that she most likely will not be interested. So because of reasons discussed above, including patient preference and level of allergy she's experiencing, this kind of moderate seasonal allergy, sounds like an alternative second-generation antihistamine is the best drug for her. She's been on Claritin for a month now. It's actually not that surprising that Claritin hasn't worked for her. Studies have shown that Claritin is really only mildly more effective than a placebo. It's kind of the least potent of the second-generation antihistamines. So I would have no qualms recommending she switch over to either Allegra or Zyrtec. Zyrtec has been shown to have some of the sedative properties that the first-generation antihistamines have just because of its formulation. So because she's 14, she's school-aged, I don't really want to mess with her school performance or sleep cycles, I would most likely recommend Allegra for her. There's a few different formulations of Allegra. There's the Allegra versus the Allegra D. The D stands for decongestant, so it has pseudoephedrine in it. Pseudoephedrine works by constricting blood vessels, which helps with symptomatic relief for rhinorrhea. So especially if she's having very bothersome nasal symptoms, I would have really no hesitations recommending the Allegra D for her. You have to be concerned about the pseudoephedrine with people that you don't want any additional vessel constriction, so patients with hypertension or glaucoma. In her case, she's 14. Unless you take a blood pressure and it's abnormal, I'm not concerned about those things with her. So for the additional symptom relief, I would go ahead and recommend the Allegra D. There's also Allegra 12-hour versus Allegra 24-hour. The Allegra 24-hour actually has 3 times the dose that the Allegra 12-hour has. So just because this is a new medication for her, we don't know how she's affected by it. We don't know how her body metabolizes it. I would recommend she start with the Allegra D 12-hour. You don't really want to flood her system in case it doesn't make her feel great. And additionally, because of the variations in different body metabolisms, the Allegra 24-hour might not last her for the whole day, and then she has no recourse. She can't take a second tablet of the medication if it doesn't last her the whole day. Whereas the Allegra 12-hour, by spacing out the frequency of the dose, you're more likely to actually get that 24-hour coverage. Allegra D has a few adverse drug reactions that are important to keep in mind. Most of them, interestingly enough, are because of the pseudoephedrine. So this includes the increased blood pressure and the arrhythmia or dysrhythmia. If she started to experience that, it would be easy enough to switch her over to the Allegra without the decongestion component. Headache and dizziness is a drug reaction to both the Allegra and the Allegra D. You're more likely to experience the headache or dizziness with the Allegra D just because of that vessel constriction that you're inducing. So again, headache, dizziness, increased blood pressure, and arrhythmia. If she experiences any of these, it's easy enough to switch to the Allegra. Other than that, there aren't major drug reactions to consider, except of course any hypersensitivity to any compounds in the drugs. In terms of monitoring the efficacy of the drug, this is really measured via the patient's symptom report. So she will know if she has relief from her allergy symptoms, and it sounds like she would feel comfortable coming in if she didn't have relief after being on this medicine for a stretch of time. What is important is to take an accurate blood pressure reading before suggesting Allegra D. As we've discussed, pseudoephedrine can increase your blood pressure. So if she already has hypertension or you're already concerned about that, it's definitely worth recommending the Allegra and not the Allegra D. Again, since she's 14, this most likely isn't a concern for her unless she has some sort of underlying condition. So important to keep in mind, but not of the utmost importance for this particular patient. The key things that Kyla has to take in mind when taking this medication is that since it's a 12-hour medication, she'll be taking it twice a day, once in the morning and once at night. It's also an extended release medication, so it's important that she does not chew, crush, or cut the pill in order to maintain its extended release, so she actually has symptom relief for the whole day. It is interesting, they do recommend not taking Allegra D with any fruit juice, grapefruit, orange. This is because it can inhibit some of the benefits from Allegra D. So you're kind of just negating taking the medication if you do it with fruit juice. In terms of when she should take it and course, she can really take it whenever she's feeling symptomatic, and when allergies are no longer a consideration for her, she can stop. There's no withdrawal, no need to taper off. It's pretty flexible in that way, and so pretty nice. She can use it to treat herself symptomatically. Because Allegra D contains pseudoephedrine, the main concern that you have with other over-the-counter medications is that pseudoephedrine overdose is possible. This would feel like dizziness, anxiety, restlessness, a high heart rate, tachycardia, or high blood pressure. It can, when very serious, lead to seizures. It really has to be quite a large amount before this happens. But it does mean that it's important to keep in mind that any other over-the-counters that you take can contain pseudoephedrine. So think Sudafed, really any cold medication that's a decongestant. So Kyla or her parents will need to be sure that they're cautious when it comes to other over-the-counters to make sure that it doesn't contain more pseudoephedrine. If she was just on Allegra, there's really no interactions with other over-the-counters noted, which is nice. In terms of educating Kyla about next steps, I would be sure to tell her if she developed that headache or dizziness that we discussed above while taking the Allegra D, she could probably just switch to Allegra without the decongestant without checking in with her provider. So no need to go through the hassle of another appointment or trying to reach someone on the phone. If that doesn't work, she could check in again with her provider, with me. It's also within her purview, since Zyrtec is another over-the-counter medication. She could just switch to that and give it a try. It is one of the stronger, or the strongest, second-generation antihistamine. So while it's worth warning her about the potential sedative side effects that some patients experience, it's a great drug and some patients really love it. So it could be the one that really helps her with her seasonal allergies. In terms of moving on beyond the oral antihistamines, I think it's really worth assessing the risks and benefits of something more involved, like immunotherapy. The over-the-counter oral antihistamines that we've been talking about are fairly ubiquitous, pretty cheap. So we're talking $10 to $15 for a month's worth of medication, and very easy to find. You can find them at the grocery store, at Walmart, at your pharmacy, anything beyond that, and you start to get in the realm of needing to refill prescriptions, to go to doctor's appointments, get it cleared by insurance, and it does start to become pretty expensive. When you're talking about immunotherapy, subcutaneous injections, those injections can cost a couple $100 per shot. They also are therapies that you can't come on and off of as easily. For the immunotherapy injections, for example, you really need to be on them for many months, and some patients are on them for their life. So it's important to think about, since in Kyla's case she has seasonal allergies, how worth it is it to get more intense with her treatment when it's unclear from this case study how many weeks out of the year is she experiencing discomfort, and just how extensive the effects of that discomfort is on her quality of life currently. So is she having any sleep disturbances? Is it affecting her school or work performance? Is it exacerbating any underlying conditions like asthma? Those are really the types of questions you need to ask yourself before bringing out any of the more intense allergy medications that I discussed at the beginning of the presentation. So that's the presentation on Kyla. Thank you for listening, and I look forward to hearing the rest of your case studies.